converting enzymes. So ACE inhibitors is angiotensin converting.
Hello, good morning, everyone.
Good morning, Professor Straw.
Very good morning. How's everybody?
Good morning, good.
Very good morning. I can see but 4 students still showing absent. Simon, Catherine, Tatiana, and Ishan. These are the students still showing absent. Any questions you may have while we're waiting for the rest of the students to join? Excuse me.
I have a question, Professor Straw.
Yeah.
You were born here or outside of the country?
No, I was born in India.
India, okay.
Yeah.
So you've been living here for a while in United
Yep.
States?
Yeah, long time.
Mm. Which part of India are you from?
I'm from northern state, Punjab.
Punjab.
I have a question, but it's referring to last week's material or the test this week.
Yeah.
The acronym ACBD, I know it's alpha constricts, but I know alpha 2 dilates, right?
So we are talking about, yeah, alpha 1, we're talking about, and then BD, we then, that also, when we talk about some asthma patients can cause constriction, bit of blocker. So we need to know exactly, which receptor it is.
Okay. So it's 1. Okay. Thank you.
Mhm. Okay, so I'm not sure where the rest of students are. Can someone please drop a text in your groups, maybe if they're having any issues to join? You have Tatiana and Ishan. These are the only 2 students showing absent. Let's move on. We'll see when they join. Right. Can you guys see my full screen? Yes?
Yes.
Okay. Thank you. So we'll be going over 3 chapters today as well. First one is adrenal drugs. So we'll talk about the issues relevant to this gland and whatever the hormones released from adrenal glands and types of medication use, some common medications, contraindication, indication, interaction, adverse effect, a kind of info we'll talk about, and then important aspects of your nursing care plan when your patient is on one of those medications. First of all, let's talk about the problem. The problem when your patient needs one of these medication is related to adrenal gland. Okay, so if they don't make enough, the condition is called adrenal insufficiency. That's umbrella term used. Adrenal insufficiency, that's not sufficient to make enough. Now, as far as your adrenal gland, as you can see in the picture, they sit on top of, they're tiny ones, they're sitting on top of the kidneys. That's why it's called suprarenal on the kidneys, suprarenal glands. They're a triangular shaped gland, on top of both kidneys. So they produce hormones which regulate metabolism, immune system, then blood pressure, response to stress. These are the common functions. And these hormones of this from, there are two parts of it, adrenal medulla and adrenal cortex. And both lobes release different type of hormones. When it says adrenal medulla secretes catecholamines, it just means the chemicals or the chemical messengers. So they're epi and norepinephrine, epinephrine, norepinephrine. And whenever they are released, they cause constriction of the vessels and they will increase the blood pressure as well. On the other hand, adrenal cortex secretes the corticosteroids, gluco and mineralocorticoids. Okay. And these, if we talk about the glucocorticoids, so they basically have your anti-inflammatory action. And then your mineralocorticoids, more your sodium water balance. Okay. Glucocorticoids, mineralocorticoids. Once again, your glucocorticoids are your steroids. Main function is as anti-inflammatory. So somebody asks you, what is the primary function of corticosteroids? Well, to reduce inflammation. So when the gland doesn't make enough, these drugs are given which mimic or enhance or inhibit the action based on what we're giving to increase or suppress the release of hormones which are produced by adrenal cortex or the adrenal medulla. So adrenal drugs, they're used in like different type of clinical settings, including treatment of your adrenal gland disorder, inflammatory conditions, in shock. These are common usage of these drugs. Now, if you talk about glucocorticoid, let's pick up some example, like your hydrocortisone, betamethasone, prednisone, prednisolone, dexamethasone. They're all your steroids. And once again, as an anti-inflammatory as well as immunosuppressant. They suppress the immune system as well, so your patient will be high risk of infections. They're also used, like these steroids are to suppress the immune system in patients with organ replacement, who has a foreign organ transplanted. So in order to prevent rejection of that organ, transplanted organ, you have to suppress patient's immune system because it will attack, assuming it's a foreign body. And these steroids can also be used in respiratory inflammatory condition like your asthma, and also in rheumatoid arthritis, or IBD, which is your inflammatory bowel disease. And as I said, if the adrenal gland is not making enough for the condition called adrenal insufficiency, excuse me, and a good example would be Addison disease. In Addison, patient is deficient, and in Cushing, they're making too much. As far as mineralocorticoids, so they produce similar type of action as aldosterone does. They regulate, as I said, sodium and water. Sodium and water. Example, your fludrocortisone, very common example. Um, okay, so next slide. Let me just go over what we just talked about, but just in a slightly different way. So glucocorticoids. So this green portion tells you that what is the therapeutic effect, what they're used for, and the bottom one, it tells about unwanted side effects associated with that. As far as on the blood vessel, it decreases the blood vessel permeability, but here on immune cells, your organs and tissues, as I said earlier, the primary function anti-inflammatory, and then as an immunosuppressant, uh, to suppress allergy response from the body. Pain relief. Now, pain relief is not direct, it is indirect. Means if the patient is experiencing pain because of inflammation, by suppressing the inflammation with steroids, then the patient feels better. Okay, so that's a secondary response. As far as the side effects, because we know it causes immunosuppression, your patient will be at high risk of infections, myopathies. Also, long-term use. Long-term use can cause their bones to become weaker, especially old population. Skin can become thick with the long-term use. As far as metabolic issues, remember, anytime patient is taking steroid, we talked yesterday as well, the blood glucose will be high. So blood glucose will be high. Also long-term use, not for a few days. They can gain weight and they may also retain more fluid. And they may experience symptoms similar to Cushing's syndrome, that moon face, buffalo hump, more fat on the tummy, those symptoms. And once again, long-term use can cause psychiatric symptoms as well, but that's long-term. Another important aspect is if somebody has glaucoma, cataract, it can increase the intraocular pressure, which increases the risk. And another one is they increase blood pressure. So blood glucose, blood pressure goes high. Okay. Any questions so far?
No questions so far.
All right, let's move on. Now, indication, what we use for, as we just talked about, in that umbrella term called adrenal deficiency or adrenocortical deficiency. That's what we use it. Or somebody's having severe infection, severe inflammatory condition, disease, dermatology issues, um, and organ transplantation. These are very common ones. Okay. Contraindication. Contraindication. Now, as we're looking on the previous slide, under the side effects at the bottom, so whatever it can cause or make those conditions worse, well, if somebody already have it, that is probably a contraindication, such as somebody has um, glaucoma, which is severe, that could be contraindication if it is severe. Um, Somebody's having an acute fungal infection, or they have sepsis, those could be a contraindication for the use of these medication. Now, as far as your diabetic patients, we know it can increase the blood glucose. Whether it can be used, absolutely yes, but we may need to monitor the blood glucose more frequently. Or if we're using it long term, we may need to adjust the dosage. And once again, more in a visual way, same side effects here again. The patient, hypertension, blood pressure go up, and so does the blood glucose. Osteoporosis, long-term use can make their bones weaker. Increased appetite. They will feel hungry, they will eat more, they will gain weight. Steroids given later during the day in the evenings can keep your patient awake. So usually given in the morning, also that's when your body release corticosteroids. So to mimic the action of the natural production, the best time to give them is in the morning. For patients with glaucoma, they're at high risk because of increased intraocular pressure. Now, we know that it suppresses the patient's immune system. So patient's immune system becomes weaker, then the bad guys become stronger, and they are at high risk of infection. They can get sick quick. Long-term use, not short-term use, long-term use, if somebody already has that underlying condition, emotional disturbances, more towards the depressive phase. And it can cause the body to retain more sodium and more water, and the patient may demonstrate edema. Then long-term use can cause the Cushing symptom, where they have more fat on the belly, this buffalo hump, moon face, and hirsutism. These are the unwanted growth of hair on the body, where it shouldn't be. Then infection we talked about already, and hypokalemia. It may cause a low level of potassium. It causes sodium and water retention, making it more diluted, and potassium level goes down as well. The potassium goes out more, and very commonly GI symptoms, but those are not that severe or not big concern. This is another slide, just in a different way, different pictures, but same information. Okay. Adverse effect, same. Here it's more just the words in there without pictures, but it's same thing. Now, as far as interaction, remember that these drugs can cause hypokalemia, the potassium level to go down. So if your patient is taking non-potassium sparing diuretic, that will make hypokalemia more worse. So if your patient is on this medication, it's better to put them on potassium sparing diuretic who let the potassium stay in the body so that the hypokalemia does not get worse. Everybody understand that concept, why we are saying that? And a good example would be spironolactone, which is a potassium sparing diuretic. It allows water to flow out, but it let potassium stay in the body. So anytime patient potassium low, they need diuretic, put them on spironolactone. Okay. Given along with NSAIDs, aspirin or NSAIDs can put them at risk of GI bleeds. Okay, patients NSAID along with steroids, they're at a high risk of GI bleed. So try not to give with anti-inflammatory. If you do, well, make sure they take it with food to reduce that risk. Okay, this is just a tool if you want to use, or you can create your own to remember what it's used for and what are their adverse effects. Are they the same what we saw previously? Okay, now let's talk a little bit. We don't need to dig too deep, but basics. Prednisone, prednisolone, methylprednisolone, which is metal dose pack as well. You may have seen it, where it comes in a pack. Where the dosage, the tablets are packed in a certain pattern, like more on day one, less next, so on. So like 5 days. So you start with like 6, 5, 4, 3, 2, 1. This is how the pack comes as. But you may come across prescriber writing it not as a pack and then tablets, starting with more and then every day decreasing it. Do you know why we do that? What is the reason behind that? No reason? Okay. First of all, why we are giving it? Let's start from there. Either the patient is not making enough, or patient, because of a condition, they need more. If somebody's having a respiratory condition, inflammation, right? They have asthma attack or something, and then you need to suppress it. Well, you need additional support. Now, additional support should be temporary, not permanent, right? So you support it and then you slowly withdraw it. It's like somebody, they got injured, they needed crutches, they start using it and then slowly they kind of put up more from their end and try to use less slowly day by day. It's not you give them crutches and as soon as they're trying to put weight on, you pull them away, right? They will fall because they're not prepared for that. And you need to give them time to develop strength on their own and carry on from there. Similarly, we are giving it to the body to provide additional support, but we cannot do that. Hey, okay, here you go, 5 tablets today, and tomorrow we didn't show up for help. The body was not expecting that. It goes into like shock. Where did it go? Body is not prepared to produce excess. Now what we do is, hey, here you go, 6 today. Body's thankful. And next day we say, hey, look, we gave you 6 yesterday, but you got to work towards your own production now. I'm going to give you 5, but you got to make up 1 yourself. Body says, okay, that's fair. At least you're giving 5, I can make 1, but if you give me 1, you want me to make 5, I can't. So next day you say, hey, look, yesterday was 5. Not pulling it back, but I'm going to give you 4 today. You got to come up with 2 from your side. And body agrees to that. Next day you reduce another one and another one. And by the time you're pulling it completely, the body started making its own. Make sense? That is the reason. So steroids should never be abruptly stopped. Okay, they should be tapered down slowly, right? Casey, you have a question?
With this decreasing dosage, what happens if a patient misses a dose?
Patient, there are always kind of, cases, chances patient misses a dose. Now it depends on what it's used for and the severity of the condition and how long ago was the last dose. They may take the missed dose or they may have to skip the dose based on when was it and what are the risks if they don't take it. Okay. If it's like they were supposed to take at 8, it's 9 o'clock or 10 o'clock, most likely it's okay if they take it. But if it's about time to take the next dose, probably skip. Okay. But if patient is experiencing severe symptoms, well, then I don't want to skip it. Then I would give it. Okay. All right. Prednisone, methylprednisolone. So starts with prednisone, and they're all like precursors. One develops from another. They produce similar kind of effect what the cortisol uh, produced by the adrenal gland does. So it's a strong anti-inflammatory drug as well as an immunosuppressant. So used in like asthma, somebody has severe allergies, somebody has an autoimmune condition such as rheumatoid arthritis, which is an autoimmune condition when their own immune system attacks own body part, assuming that's a foreign intruder, starts damaging. And now, once again, if somebody asks you what is the mechanism of action, how do they work? Well, simply it suppresses the immune system as well as suppressing the inflammation in the body. And we know what are the side effects associated, like high blood glucose, high blood pressure, high risk of infection, long-term use weight gain, those kind of symptoms. And same will apply to others as well. So we talked about that already. Methylprednisolone, same thing. And this is a different dosage form, but IV, but comes in that dose pack as well. Once again, the purpose is same as an anti-inflammatory or immunosuppressant. Okay. Here's fludrocortisone. Fludrocortisone is a mineralocorticoid. It's a mineralocorticoid, which is on the right-hand side. So this is used in Addison's disease. Addison's, they don't make enough. They don't make enough. Okay. And now adverse effect, same. High blood pressure. So very important to know these things. Okay, blood glucose, blood pressure goes high. These are important aspects. So please remember these things. And then sodium and water retention. And sodium water retention, is also a contributor to increase the blood pressure even more. There's more volume, more sodium, the heart has to work more, causing blood pressure to go high. And if your patient is diabetic, it's real important that we check their blood glucose more frequently and adjust any dosage if we need to of their anti-diabetic drugs, because we know that long-term use will going to increase their blood glucose, even though it's for a few days. Just say like, okay, they will be taking it for 7 days, 10 days. They're in the hospital for severe um, infections, respiratory condition, or anything else where they need this drug, but they have high blood glucose, and then we may need to adjust the dosage of their insulin while they are on this medication. Okay. Nursing implications. Well, they are related to whatever these drugs does. Okay, so we need to make sure patient is aware about the risk, and we do everything to prevent any complications. A patient able to identify the signs and symptoms or adverse effects associated with this drug, such as edema and those kind of things. So always get set a baseline of vital signs, their height, weight, because I'll give you an example. If they're used for some type of autoimmune disease on a long-term basis, and if it's a kid, their growth would be a big concern. Their growth will be slow. So we need to monitor their growth closely if it's a child. And if somebody has an autoimmune disorder, then we need to keep a close eye on infections, also on vital organs, so that it can be identified at an early point. And once again, very important to educate the patient not to abruptly stop them. Always taper them slowly, gradually taper them. That's extremely important. Okay. And when we talked earlier as well, same thing. The 5S's means they are at high risk of getting sick because their immune system is down, right? Long-term use can make them sad because we know depressive symptoms they can experience, and decreased libido with long-term use. Salt retention, sodium, they hold on to sodium and water, causing edema, weight gain, so we need to monitor that. And sugar, especially in your diabetic patients, they need more frequent monitoring and dose adjustment. And it's always better to give them with food or milk or something, not empty stomach, because that can put them at a high risk of GI issues, either GI upset, or if they are taking NSAIDs, they're taking aspirin, that can put them at a very high risk of GI bleeds. Okay. Now, if we talk about specifically inhaled corticosteroids, like your asthma COPD patients, make sure that after each use, every use of inhaler, you educate your patient to perform oral care. Oral care, very important. If they don't, high risk of oral fungal infections, oral thrush we say as well, right? But we use nystatin for that, but that's a high risk. So anytime there's an inhaler corticosteroid, you educate them to perform oral care after each use of that inhaler. Also, especially if they're kids and they're old, because kids, their immune system is or has not developed stronger yet, and older patients, their immune system is not strong anymore. It's old machine, getting weak. So they are at a high risk of getting sick as compared to normal healthy adults. So you tell them, if you're taking this medication, please stay away from too sick people. People who are real sick, stay away from, because your immune system is not strong and this medication will suppress it even more. So you have a very low ability to fight with these bad bugs. So if somebody's real sick, stay away. Now, because we are giving the medication, suppose there's an adrenal insufficiency, patient is not making enough of it. and we have to give it to the patient, make sure we are giving at the same time so that the patient has consistent level of medication in the body all the time. Okay, and one more time, as we talked previously, never abruptly stop them. Never ever. It's called adrenal crisis. The body is not ready to replace. That's why we always taper them and then monitor the therapeutic effect and monitor the adverse effect associated. Okay. Any question from this chapter?
No questions, Professor.
No question? Okay. Uh, okay, just want to check. The Tatiana Ishan ever joined? No? Did anybody drop a text in the group? Yeah? No response? Okay. Alrighty. 9. Do you guys want to take a little early break? Yeah. All right. So let's take a 15 minutes break, okay?
Thank you.
Thank
You're
you.
welcome. You're very welcome. Okay, welcome back, guys. Let's turn the cameras on.
Professor, Sean's power went out, so he won't be able to log in probably till another 20 minutes, he said.
Okay, thank you.
You're welcome. And then Tatiana's here.
Tatiana?
Yeah, sorry. My alarm did not go off.
Oh my goodness.
I know, I woke up and I was like, wait, oh my gosh.
Well, like 10 alarms.
I should have, honestly.
I do that all the time.
Yeah, sorry.
Okay, what time did you join?
Literally, I think right when you guys just went on break.
Okay. Oh, like around 9:45?
I believe so. Yes.
Okay. Okay, I just checked you in.
Thank you.
All right, let's move on to chapter number 2 of the day. Antihistamine, decongestant, antitussive, expectorant, quite a few things in chapter, not too complex, but important. And they are used very commonly, so stay focused. So we'll talk about antihistamine conditions associated with histamine release, and that's why we use these antihistamine, such as allergies. Then decongestants for congestion, and cough medications for different type of coughs, and any contraindication, interactions, adverse effects, and important things to include when your patient is on those medications and developing nursing care plan. First of all, one of the most common conditions, a common cold, which is a viral infection. Because it is a viral infection, and majority of them goes away on its own, but some severe issues with certain viral infection may need a antiviral drug, but you do not give antibiotics for viral conditions because they do not work. So common cold is a viral infection, usually affecting the upper respiratory tract, and from, excuse me, above. And then nose, throat. So this is the part where the major impact you will see. Your lower respiratory tract when lungs are involved. There are there are hundreds of these viruses, and all of them do not cause that level of sickness and not involved with this human viral infections. But even the known ones, there are a lot. Um, so usually with your common cold, um, patient experience like a stuffy nose, runny nose, they're sneezing, might be coughing. Uh, some patients may have a sore throat, headache, and some patients may experience a low-grade fever as well. And as I said earlier, usually the viral infections goes away on its own in about a week or 10 days. Okay, so your treatment plan should focus on relieving the symptoms. So it's a symptomatic treatment. Number one, rest. Number two, fluids, more fluids. And then, based on the symptoms, it may include some OTC drugs such as decongestant or pain reliever or antipyretic. Excuse me. So when patient is sneezing, there's an irritation in the nasal mucosa. Nasal mucosa, there's some sort of irritation which causes that reflux and patient starts sneezing. Now, when patient has this stuffy nose, when they say my nose is stuffy, you can't breathe well, what happens is the vessels, the blood vessels, they dilate. Blood vessels dilate and the patient feels stuffy, the passages are tight, there's inflammation. And when you give them the medication, they constrict the vessels, squeeze that inflammation there, and open up the airway, air passage, and the patient feels better. They can breathe easily. Okay, so just remember, with the problem, when it's a stuffy nose, the vessels are dilated. And the solution, the drug we give, it constricts them. You don't have to worry about that. Now let's talk about common drugs used. Lots of over-the-counter products. You go in OTC and allergies, common cold, you will see these drugs. I'm sure everybody has seen this Claritin. Yeah. Okay. Claritin. Now, if you look at the first two pictures, see, first one is Claritin, the second one is Claritin D. What is the difference?
Is one an antihistamine, one is decongestant?
So the Claritin loratadine itself, that's just the loratadine that in Claritin is, and it says non-drowsy because loratadine is not drowsy. It's a newer generation. The first generation, such as your Benadryl, diphenhydramine, they are real drowsy because they act where we don't even need them. They target other receptors as centrally as well as peripherally. You didn't need them to act centrally, but they do and produce those sedative effects. Loratadine doesn't. So that's why it's non-drowsy, or some say daytime. So this is antihistamine. But the next D mean decongestant. So it has a decongestant as well. Okay, it has a decongestant as well. Then these are cough products like Robitussin, and you may see Robitussin DMs. Same concept. Either it has a single ingredient, active ingredient, it has multiple targeting, more than one indication. Now, histamine is a culprit. This is the bad guy, okay? The body releases in response to something when it senses there is an intruder. It could be just the weather. It could be they got in contact with something, allergens, pollens, mold, all those things can cause that. Anaphylaxis, anaphylactic reaction when severe, acute. It's an acute response from the body, right? Usually EpiPen is used. Then angioedema, insect bite. When insect bite, at the same time, body release histamine. Urticaria, patient is experiencing itching. Same thing. Histamine is causing that. So what it does is your histamine causes your constriction, contraction of the smooth muscle. It increases the heart rate and increase in body secretions, right? That's why runny nose and all that, watery eyes, body is releasing histamine, and histamine is causing that. And when we take an antihistamine such as Benadryl, you guys kind of remember how you feel after taking it? Slow, sleepy, drowsy, dry, right? Because it dries out everything by blocking the histamine. Okay, this is the same thing, so we don't need to. Okay, now let's talk about antihistamines. So antihistamines, as the name says, they are against, opposite to the histamine, so they block the effect of histamine. The next question is where? Well, on the histamine receptors. Okay, histamine receptors. Next question. They say which histamine receptor? Okay. Do you know which one? Anybody knows? Is there only one type of histamine receptor? More than one? Why they're asking us so many questions, right? Anybody?
I'm just gonna guess histamine 2.
So histamine 2 exists, or you're saying that this belongs to histamine 2?
Both?
That's here a little too generous. Giving them both away. Okay. Let's know it. 100% sure, no guessing, okay? There are two types of histamine receptor, histamine 1 and histamine 2. 1 and 2. Now who's who? Allergies belong to 1. Please remember that. Histamine 1 belongs to, allergies belong to histamine 1. And H2, anybody knows what is H2? Anybody can shed some light? No? H2 associated with acid reflux. Okay, so just remember that H1 belongs to allergies, H2 belong to acid. Have you ever heard about ranitidine, famotidine, cimetidine, right? They use for acid reflux, right? They belong to H2 receptor. Everybody clear? Any question? If someone's still not 100% clear? Thank you, Kayla, for writing them down. So H1, allergies, H2, acid reflux. So if somebody says, I'm taking H1 receptor blocker or H1 receptor antagonist, they're just making it a little hard for you. All they're taking is maybe Benadryl or something, right? Or loratadine. But if they're saying they're taking H2 receptor blocker, that means they're taking something for acid reflux. And those are your ranitidine, famotidine, those are the ones. Okay. Now, pick up always, whenever you read these classes, classification of drugs, always stick a label. What that means is a couple, at least 2-3 drugs, common ones, easy to remember, most commonly used, just stick them on right next to that so that you can remember. Okay, such as with H1, attach Benadryl, diphenhydramine. Very easy to remember, common drug. So that will tell you, oh yeah, these are associated with allergies. Well, when you take these drugs, how do you feel? Slow, sleepy, drowsy, dry. What should you do? You should not drive. You should not drink. Excuse me. You should drink more water, that kind of stuff. And when you're talking about H2, well, stick your like famotidine, ranitidine, that'll tell you, oh, the patient who are taking that, well, they're probably having that acid issue. And we give that in the morning, those kind of things. So let's talk about them now. First of all, how do they work? So antihistamine, they block histamine where? At the histamine receptors. Which one? H1. Well, that's how they work. They block the histamine 1 receptor, preventing the histamine from binding to the receptor. And if they cannot bind, they cannot produce effect. Let me give you a simple example. You're going to a busy restaurant, okay? You're looking at a table before entry and just waiting to be seated, and there's a lot of other people there, and you're like, oh my goodness, I hope I get, that table soon. There are 4 chairs, right? So you guys are waiting for that, and then someone else, but you came in first, and you get seated on the table and the chairs. It's blocked now, right? Can anybody else sit on that? No, it's blocked, right? They gotta wait. Well, this is how this receptor thing works. When you give them antihistamine, they run quickly and block the receptor. They go and sit and say, table reserved, no space for you. And histamine cannot bind, and until it cannot bind, it can't do anything. Without binding to receptors, there's no effect. Make sense? And that is the reason. Who goes first? They block it. If you don't give them antihistamine, well, the histamine is going to block that, and it will cause all secretions increased. And if you give them antihistamine, antihistamine is going to block, and well, histamine can't do anything at that time. Okay? All right, now, as far as antihistamine, there are different generations of antihistamine. And now also stick the label. Which one is first generation, second generation, and all that. First generation means the older generation. And now let's bring our diphenhydramine, Benadryl again, attached to that. Benadryl is the first generation. Let's move on to second generation. That means these are newer generation. Now pick up your Claritin, the loratadine, okay, attached to second generation. Now we know which one are first, which one are second. We know the examples. Well, why do we even have the second generation if you have the first generation? It's not a new car model, but it's the same concept, improvement. The older generation has the efficacy. No problem with the efficacy. Benadryl, very effective. But we only wanted to block the histamine response, like, runny nose, watery eyes, all that kind of stuff. We didn't want to go to sleep and feel drowsy or dry. But Benadryl does. So it not only peripherally, centrally works as well, cause those effects, which we didn't want. So here comes the second generation, which blocks the histamine receptors, but it does not act centrally and do not cause those unwanted adverse effects. Clear?
Yes.
Okay. Because they do not enter the brain. Okay. So this is how it looks like. Patient, different symptoms because of histamine. And once you block the receptors, well, you block the release of histamine and all these symptoms disappear. Okay. We just talked about that. Now, once again, histamine 1 receptor antagonist, histamine receptor blocker, antihistamine, same thing. Same thing, okay? Nothing different. So, once again, example. They're your H1, allergy one, and Benadryl, loratadine, cetirizine, levocetirizine. These are all your H1 receptor antagonists or blockers. Now, what they do? Well, they're antihistamine, so the properties are antihistaminic properties, but along with that, unwanted package comes at the door, which means unwanted effects, anticholinergic, sedative effect, makes you dry, constipated, drowsiness. So it has those properties as well. Okay. Here comes your H2 receptor antagonist or H2 receptor blocker, like your Pepcid, Imodin, Zentek, Ranitidine. These are your drugs used to reduce the gastric acid. Somebody's having acid reflux, somebody's having gastric ulcers. That's what they're used for. And they end in tadine, okay? Cimetidine, ranitidine, famotidine. So that's what they end with. So just pick up a couple of examples. Remember what they are, what they're used for. Next question is, well, we knew H1 receptor blockers, how they work. They block the histamine receptor, histamine 1 receptor. How does these work? Well, they are H2 receptor antagonists, so they block the histamine 2, number 2 receptor. Where it is? It's in the stomach. Acid is where? In the stomach, right? So it inhibits the proton pump to some extent, not completely, some extent, who produces the acid. So they kind of reduce the gastric acid secretion. Now, how they're different than PPIs, proton pump inhibitors, your omeprazole, lansoprazole, pantoprazole for acid reflux, right? GERD, they use for. Well, those ones, the PPIs, they block the proton pumps completely. But these ones, they reduce the production, but they don't completely block it. Okay, once again, generations of antihistamines, first generation, second generation, third generation. So Benadryl, pick up an example. Benadryl, promethazine, they're old generation. And the problem with them is they make you more slow, sleepy, drowsy, dry. Relate that if they're going to be slow, sleepy, drowsy, dry, what are the potential problems and what are the solutions? Now, for example, slow, sleepy, drowsy, well, it's a safety risk, especially older patient population. They might get more confused, sleepy, and when they get up, postural hypotension, blood pressure might drop. They may fall. Somebody driving after taking Benadryl, well, not safe for them and people around them. Correct? Solution. Well, safety precautions. Don't drive, don't mix with anything else, any sedatives, opioids, alcohol, which will suppress your CNS even more. Drink more water, consume more fiber to address the dryness and constipation. Second generation are more advanced, less adverse effects as compared to the first generation, like your loratadine, which is your Claritin, and your cetirizine, Zyrtec. Then comes the third generation, which has no sedative effect or anticholinergic effect, slow sleepy drowsy effect, such as desloratadine. They are developed further from this loratadine, desloratadine, and this is your Allegra fexofenadine, and levocetirizine. This purified further from cetirizine by reducing unwanted adverse effects because of them entering into the CNS. Okay, any questions so far? Everybody awake, guys? Yes? Because we're talking about slow, sleepy, drowsy drugs here, right?
We're awake.
All right. Just making sure. Okay. This is just another way put up in the table like what they do, like what histamine does and what antihistamine does. On the cardiovascular system, when the histamine is released, they dilate the blood vessels, but when you give antihistamine, it reduces the dilation. On immune system, when histamine is released, what acts on the mast cells and causes or produce the allergic response. And when you give them antihistamine, it blocks the histamine from binding to the histamine receptors, H1 receptors, and blocks that effect. And on smooth muscles, when histamine is released, secretions are more, right? Watery eyes, runny nose, all that. And when you give them antihistamine, it dries out, reduces the secretions. Okay. Once again, older generation, newer generation. Older generation has unwanted effects of slow, sleepy drowsiness, and newer ones doesn't. The reason, which I mentioned previously as well, the older ones, they act peripherally as well as centrally. That's why they cause the unwanted effects. Once again, stick the label. Benadryl, diphenhydramine, chlorpheniramine, meclizine, promethazine, these are all old generation ones. And these are newer ones, like your Claritin, loratadine, Zyrtex, is in Allegra is your fexofenadine. So they do not cause the unwanted adverse effects of sedation stuff, okay? Or to, I would say that a little less, if not completely. What they are used for? Well, whatever the problems we were talking about, like your allergies, very common allergies. Or somebody is having allergic reaction because of, could be from a food, getting in contact with something, they inhale something, or insect bite can be used. And some of them can be used for motion sickness, like your meclizine can help motion sickness. Then to address some of the symptoms your Parkinson patient experience because of the drugs they take, in order to minimize that, these drugs can be used as well. And some patient kind of, feel benefited for like sleeping issues as well. Okay, now who should not be using them? Who should not be using? Well, we know that it makes people slow, sleepy, drowsy, dry. So somebody's CNS is depressed or they're taking any of those drugs, anything severe with the respiratory system, that could be a problem. But very importantly, it's essential to prevent this risk. If the patient has glaucoma, now glaucoma means is increased pressure tension in the eye, increased intraocular pressure in the eye is high. You can also cause hypertension of the eye. Okay. Now, if they take this medication, that tension will increase. So the pressure in the eye will increase. Now, what is the risk? Well, if that pressure increase, it can damage patient's optic nerve, which is responsible for their vision. Okay, so optic nerve damage, that's a very high risk. So we should not give this medication to patient who has glaucoma and severe hypertension. That's also a contraindication because their blood pressure will increase. Looking at some of the cameras off. Daniel, then Ishan, Kayla. I don't see you guys on the camera for some reason. Sanjoy, please keep your cameras on. Ishan, are you there?
Yeah, I'm in the car, so I was charging my phone because my power is out. I'm
Oh, okay,
listening
okay, okay, okay,
through,
okay.
yeah.
Okay, got it. No worries. All right, so a few other things here, okay? A few other things. Um, somebody has peptic ulcer disease, that's also contraindication, that will become worse. Very important, pregnancy. Pregnancy is a no-no for your antihistamines, especially your first generation antihistamines. Shouldn't be taken, okay? Another important one, older males who has BPH, benign prostatic hyperplasia. They'll be real upset if you give them this medication. Now, BPH is a condition that their prostate gland is inflamed. Uh, just like say here, this is the prostate gland. So this is the urinary passage. So when it inflames, it squeezes like a clamp on a pipe. So now they are having difficulty urinating. They are having urinary retention. So their bladder is kind of backed up, and that is very inconvenient. They're in pain and they're always at high risk of UTIs, and this can actually go up and infect the kidneys as well. So if you give them this medication, they are going to make it worse, more inflamed. They're squeezing even more tighter. So it shouldn't be given to those patients. And now anybody going for an allergy testing, patient experiencing chronic allergies, well, the doctor said, I'm referring you to an allergist. So they will be testing, they'll be injecting like just small, little tiny needles, small amount of samples, and intradermally, usually on the back or like this area. And then they observe like the response, how body respond, and they try to identify what they're allergic to. So if they're going for allergy testing, make sure they discontinue the antihistamines, because antihistamine are going to block the response, and they are injecting the allergen to see the response. And if they're taking antihistamine, they won't be able to see that response. So they'll be looking at the false result. Now, we know it makes your patient slow, sleepy, drowsy, dry. So now the concern is safety. So for safety, they should not take it with anything else. The symptom becomes worse. They should not be driving, that kind of stuff. Or if they're old, tell them that let us know. Press the call light. Don't try to go to the bathroom at night alone. They may fall. Then as far as your dryness, so increase the fluid intake. Increase the fluid intake. And then they can also use like sugar-free hard candies they can suck onto, or sugar-free gums, or oral moisturizers they can use too. And in eyes, they can use the lubricants to keep them moisturized. Driving is a big thing, okay, that they should not drive. That's a huge safety risk. And equally important, and that's a high risk in older patients who are taking lots of drugs. And for example, if they're taking like sleeping pills, anxiety pills, any CNS depressants, if they're taken together, the patient will be at a high risk. So anything which has same type of effect, same mechanism of action, work on the same receptors, that's a problem. So we need to watch for that. And if patient is experiencing high adverse effects, you can suggest them to take it with food to minimize it. Okay. Any questions so far?
I had a question about the contraindications. So earlier you said that one of the contraindications for antihistamines was peptic ulcer disease, and you're talking about H1 receptors, right? Not H2, because H2 blockers are
Correct.
used to reduce. Okay.
Absolutely. Good question. Very good question. Anyone else? Any other question, guys? No? All right. All right. Okay, same thing, guys, what we talked earlier at the bottom. Glaucoma. No, 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 no. Anybody with glaucoma, make sure during assessment you ask them, do you have any other health issues? That's where you find the answer. Is it safe to give or not? Hypertension, once again, do you have any other underlying conditions? That will act as a filter. Your questions are the filters, making sure step by step if this drug is safe to give or not. Peptic ulcer, BPH, pregnancies, these are all filters. The question during your assessment, making sure you're not giving it to the patients with conditions which are contraindicated. Okay. And again, safety is a big concern, not only for your patient. If they're driving, they're going to work where they're operating a heavy machinery, well, think about people around them. It's on their mercy, right? They're safe only until they mess up. So they should not be. Very simple statement or educational point should be, please do not engage in any activity which requires you to be alert. It's that simple, no matter what. Okay, and any other drug which suppresses the CNS or alcohol, that will increase the risk. And as I mentioned earlier, to reduce the GI issues and to minimize the adverse effect, you can recommend the medication can be taken with food. Now, as far as the other concerns, we can recommend frequent oral care because we know it will make them dry. And sucking on hard candy, gum, that will keep oral mucosa moisten. Okay. Now, let's talk about congestion and then we'll talk about decongestant. So congestion, when they say, oh, I can't breathe, my nose is stuffy. Well, once again, it's inflamed nasal mucosa because of dilation. Dilation can be because of allergies or upper respiratory infections. So the drugs used, they're called decongestant, who cancel out the congestion. How? Reversing the problem. The problem was dilation of the vessels. They will constrict it, open up the passage, reduce the swelling. They will also reduce the production of mucus, making it more stuffy. So that can help your patient's symptoms. Now let's pick up some examples. Everybody heard about pseudoephedrine, Sudafed? That's a decongestant. Phenylephrine, oxymetazoline. You will see them in different forms. It could be oral, it could be nasal sprays, very common. And in severe cases, corticosteroids are very effective. Remember what they're used for. Corticosteroids, anti-inflammatory, reduce the inflammation, open up, and suppress the immune response as well, both ways. Comes in various forms, as I said, oral, inhaled, can be applied topically. So what they're used for? Well, if we're talking about congestion, so yes, they're used for congestion or the condition which causes congestion. Common cold, sinusitis, chronic rhinitis. So they reduce the swelling, open up, blood vessels gets constricted. Okay, that is the mechanism of action. They shrink the blood vessels in the nasal passage, reduce swelling, congestion. Okay, and then steroids, same thing, what we taught previously. Steroids have strong anti-inflammatory effect, and they also suppress the immune response. Here are some common examples. Intranasal steroids, like your Flonase, which is fluticasone. Okay, budesonide, beclomethasone, triamcinolone, which is Nesacort, and then top one, Afrin, that is an adrenergic drug, oxymetazoline, and the bottom one is Atrovent, which is an anticholinergic, ipratropium, anticholinergic. Now, once again, anytime, now here we're talking about nasal one, but if anytime any steroid orally used, make sure your patient performs frequent oral care and also educate them to monitor, watch for any white patches in the mouth. That is an indicator of the fungal infection. Okay. Decongestant, as we just talked about, causes the reversal of congestion, but you have to be careful that these are not used for long term, only from 3 to 5 days, no more than that. The reason, if they're used longer than that, as soon as your patient is going to stop, they may experience a rebound congestion. They'll feel that stuffy congestion once again. So these are only for short term. On the other hand, if these are oral decongestant, okay, they're not nasal. We're talking about nasal. They're only 3 to 5 days. If they're oral and you stop taking them, there's almost negligible chance, very low chance of that the rebound congestion. So the oral decongestant carry much lower risk of rebound congestion when we stop them as compared of nasal decongestant. Everybody understood? Any question? No?
Oh, I had one about phenylephrine. That's also a common like oral one, right? But hasn't it been proven to be like more of a what's it called? Like a fake effect? Like it doesn't actually work.
It doesn't what? I'm sorry. Can you say that again?
It doesn't work. I forgot what it was called. Like it doesn't actually work, but phenylephrine. No, placebo. It's more of a placebo. Phenylephrine.
The phenylephrine, I think it was about this drug, right? It was in media, I think few months ago or in here, it was about that or something else.
Yeah,
That
it
they
was
found out in the data that they didn't find it much effective. It
so
was
like if
about
you
that,
were,
right?
yeah, so you're ever like asking your patient or telling your patients about like some medications that they can take over the counter, then you wouldn't recommend that one.
You know, with again, drugs, you know, you have to be current on the information, because it wasn't the case. Like nobody knew that, you know, there's not enough data to support that. Everybody is like, yeah, it works. But sometimes it takes decades uh, to collect that data and then come up with some sort of productive conclusion that how effective something is. So it was recommended, but when you come across that kind of scenario, when you find enough data which points out that not really working well, then you should not recommend that product. I tell a funny thing, like, you know, you go everywhere, and you go see your doctor, they ask you, oh, did you take flu shot this year? Right? You ever come across that question? When you go see that, right? Have you ever looked up in the data, on the data, like the efficacy of flu shots? Has anybody ever looked up? Okay, do me a favor, just search on Google right now. Search it, see the efficacy of flu shot.
40 to 60%.
So what does tell you? That what are the chances that if you take it or you don't take it?
It's 50-50 either way.
Either way, you take it, you still 50%, then you may still get sick. And you don't take it, you still have that, then maybe 50% you get sick. Right? So these are tricky things. Don't believe what people tell you. Okay? People run multi-million dollars campaigns to sell their product. Doesn't mean it's effective, but they present the data only from certain angles, which makes you believe, oh yeah, it's essential, so important, crucial. Well, you guys are super nurses. Don't trust anybody. Do your own research. Okay? And then talk. People won't have any response to that. Because data that's the only thing which proves something, it's effective or not. It's not what my belief is, right? So you go to the doctor's office, well, it's a business, right? That healthcare, it's a big business. The pharmaceutical companies, that's a business, right? So they have to sell their product. But if they say, oh, there's a 50-50 chance, then who's going to take it? Nobody, right? So they're only going to show you one side. Same thing with these campaigns, or, you know, when these, in US, if you search, look deeper, has anybody, I'm not sure if you're, there's a Eric Closer, a writer, he wrote a book. It's I forgot what it's called. Food something. Food Inc. Has anybody a chance to read the book? No? If you have time, whenever you have time, please read that book. Read the book, because you learn a lot that maybe many of your beliefs are based on what you've been told. You never experienced, you never looked that is even true or not. Because they start conditioning our mind as soon as you're born. They start from the parents. Okay, what their kids need, what their child need. Okay, and when the child is able to see, read, watch, now the products are presented to them by various means. They need it. That, oh, I want this. They make it a need from want. You know, decades ago, they started, oh, everybody needs calcium, vitamin D, strong bones, so promote milk. Okay, everybody, yeah, to kids, hey, you need to drink milk. You need to drink milk. Well, the data says maybe our bodies don't even absorb majority of that calcium, vitamin D from that. Now, another, and I'm sure you all heard it many times, we need proteins, right? We eat meat because we need proteins. Well, that's where it stops. If you dig deeper, you see where that campaign comes from. Majority of not only the meat industry, majority of these stores you see, like you go to Food Co, you go to Food Max, you go to Winco, like these are placed strategically in different markets based on different type of consumers, targeting their mindset. Okay, just search. It's only top 3 companies who owns all of them. Just the names are different. It's owned by 3 companies. That's it. Whole America. 3 companies own everything. It just, we say, oh, you know what? I go there, they have this. I go there, they know how to target consumer mind. Technically, it's the same pocket. Okay, they run the campaigns. They run the campaigns, what you need, what should be eating, what you should be drinking. Start doing your own research to stay healthy. Don't trust others and what is good for you. Find out what is good for you. There were times when, people were not packed in these big cities, you know, less populated. They were hunting their food fresh. Okay, that was a different me. Now, say you fulfilling that the protein need, but do we know where that come from? They can put a label on. What do you know about it? How long ago was processed? What was the condition that had anything? What issues? Like majority of these products are crap. People are getting sick. Why we're having diabetes, hypertension, cardiac issues? Why? Because of the crap being given to put in. Not if it's healthy or not. They don't care about it. It's about what they can sell. By keeping the production cost low, selling cost high to increase the amount they can make. So, and it applies similarly to vegetarian diet now. To increase the production, the products they use, that's not healthy either. If you compare the food standards, or, there's so many chemicals in the fields, agricultural fields are used in US, they're not allowed anywhere in the world. Nowhere. They're banned decades ago. You go to McDonald's here in the US, you eat after 30 minutes, you won't be able to eat those fries, the burger. Right? You go to the same chain in Europe, completely different taste. There is a reason behind it. Well, that's how it goes. But I would definitely suggest, like, don't just follow anybody. Follow yourself. You are smart enough to find out what is good for you and not, as long as you do proper research. And research is never based on single writer, single resource. Dig multiple resources. That's where you get some sort of sense that what is right, what is wrong. Anyways, let's move on, guys. I kind of deflected from our chapter, but remember, it's just the common sense requires to be a good healthcare worker. Common sense. Okay, now, once again, in order to prevent the rebound congestion, especially the nasal ones, we are telling them not more than 3 to 5 days. Talked about this. This is just a visual thing, like when they have the dilated vessel, and this is how the nasal passage looks like. It becomes tight and they can't breathe. And when you give them these decongestant, they squeeze the vessels, and now the passage becomes open. But remember, constriction causes what effect to blood pressure? Silent effect? Guys, wake up.
Increases your blood pressure.
Increase the blood pressure. So always keep an eye on the blood pressure. If they are experiencing some anxiety, kind of palpitation, that look into that. Maybe they took a little bit too much, or the body responded excessively towards these drugs. So they're vasoconstrictors, hypertension risk. And once again, don't give it to patients who can be at a high risk, such as glaucoma, hypertension, BPH. I'm repeating this information again and again and again. If you notice, how many times I talked about it? Many times, right? Same information. Reason is, it's very important. Not only you'll be tested on things, but this is going to be important for you to do well in NCLEX, as well as keeping your patients safe. Okay, I'm not worried about that. Okay, now also this gentleman here, monoamine oxidase inhibitors, they can increase the blood pressure severely if they're taken along with decongestant. In a general statement, monoamine oxidase inhibitors are not a good friend of any drugs. They don't like others, the loners. Okay. Also, educate your patient not to drink too much caffeine along with that. Okay. And if their condition persists, even after taking that, make sure that they go see the doctor. Now, as far as cough is body's normal reflex. It's a response to something. To clear the airway, it could be because of irritants such as mucus, smoke, or body sees anything such as food particles as a foreign particle going to the airway. It tries to expel. Or it could be caused by some infections. Be common cold, could be some chronic conditions. Patient may have asthma, COPD, bronchitis, can cause cough. And based on the cause and the type of cough, we select cough products. Okay. Anybody knows the type of cough?
Dry.
Types of cough. Just a dry?
Productive.
Productive.
Yeah. Dry and productive, or you can say dry and wet. Wet means the productive cough. And the Productive means there is a product involved, and the product is the mucus and secretions. So cough reflux, it helps help protecting your airway, lungs against the irritants, and this expulsion, the air expulsions, is very strong. We don't feel it, but it's extremely strong that when it comes up. Now, going back to what I asked previously, that types of cough, productive and non-productive. The productive means it has a product, means mucus secretions are involved. Non-productive, there's no product, no mucus, no secretions. It is just the cough, means just a flat, dry cough. Now the solution would be, if it's just a dry cough, there's no mucus, we don't need to do anything about the mucus, we shut the cough down or work behind whatever the reason is. But if it's secretions, we have to think beyond that shutting down the cough. Well, we need to make sure that if it's because of a product, the mucus, is it because of allergies? The secretions are there, but we may need something additional. But in order to make it easy to expel the product, the mucus, the secretion, we need to make them loose, maybe less thick. How? By telling the patient to drink more fluid. So when they're less thick, they can be expelled out easily when coughed. If they are too thick, even the patient is coughing, but still they're not able to expel the secretions. And that's how the product is different for your dry and productive cough. We'll talk about it. Okay, here you go. These are important, okay? Know them. What are they? They're all for cough, but different type of cough, different action they produce. Antitussive, expectorant, and mucolytic. Now let's talk about antitussive. They are the ones who act to suppress which cough? Which cough? Anybody? Dry cough. Antitussive. They are shutting off the cough. They are stopping the cough. Dry cough. Examples. Your codeine strips, right? Dextromethorphan. It's an over-the-counter product. That is your antitussive. It's for dry, non-productive cough.
Is that like the same thing as Robitussin?
Okay. Now, expectorant. Now, expectorant means there's something expected. Product here is mucus, secretions. So this is for wet, productive cough. Now, what these drugs do is that it increases the mucus production and also make it thinner so that it's easier to expel out, such as your guaifenesin. Because it tries to expel the mucus from the airway so that they become clear. Now the third ones, mucolytics. Muco means mucus, lytics to break down. So these drugs break down the mucus, making them easy to expel out. They are thick, right? And it breaks them down. Usually these are given to your COPD patient. That's acetylcysteine, because they have very thick mucus, can't expel it out, and they have time breathing, so you need to break it down. Your COPD, and also very important in commonly used in cystic fibrosis. This is another visual aid for you to kind of understand how these works. For example, here, your benzonate. Benzonate, they're called Tesla pearls. These are a prescription pills. They look similar to like your fish oil capsules. It seems like that. They're usually taken 1 POTID for 2 days. Okay, that can cause dizziness. So that's one angle. Slow, sleepy, drowsy, dry with that. So this is an antitussive. What they do is they numb the cuff center, or the sensors where the lungs are getting triggered and causing cough. They numb that on the lungs. Okay, the cough response on the lungs. Then guaifenesin, which is robitussin. So what does it do? It irritates the mucous membrane so that cause more cough, thins so that it can go out. And the mucolytics are the ones which break down the mucus so that they can be expelled out. Those are for more severe conditions like your COPD and cystic fibrosis. That's very thick secretions that can't expel it out. Okay, and now once again, they are taking this medication. For example, say your guaifenesin. Now it's going to irritate, going to cause more cough, and try to thin the mucus to expel out. But it's equally important you educate the patient to support that system. How? Drinking more fluids to make it even more thin so that they can expel it out when they cough. So that's a very important point, increasing the fluid intake. Okay, once again, antitussive for dry cough. Everybody understand that? All clear? Antitussive for dry cough. Suppress the cough reflex. Example, dextromethorphan, codeine. How do they work? Now, they suppress the cough reflex in the cough center in the brain, in the medulla. So that's important to know. What is the mechanism of action? And whether this is opioid, non-opioid, they pretty much work on the same cough center in the medulla in the brain. Okay, so know that please. They suppress the cough, directly acting on the cough center in the medulla. And adverse effect will be the same what opioids cause. Slow, sleepy, drowsy, dry, and overdose can cause respiratory depression. So this is a non-opioid, your Delsim, which is your dextromethorphan. Same place. Acting directly on the cuff center in the medulla. And your benzonate, brand name Tesla pearls. It's on the bottom. That's how they look like. They exactly looks like the fish oil capsules, little tiny pearls. And they numb the lungs, the receptor at the lungs. They just numb them. Okay, indications, well, we've been talking about cough from last 10 minutes. That's what we use it for, right? Contraindication, anybody allergic, don't give it to them. Opioid should not be given to somebody who's at high risk of opioid dependency, or they have a respiratory condition, asthma, COPD, cystic fibrosis. Opioid should not be given because that will suppress the respiratory system. Okay, any questions so far, guys? Any question? No? But it's okay. All right. Just complete few more slides and then we'll take a break, okay? Right. So this is your adverse effect based on where the drug acts on what receptor. That's how you can know what are the adverse effects associated with that. We know that opioids causes sedation, slow, sleepy, drowsy, dry. That's what the concern is. How to give a solution, provide a solution? Well, if they are slow, sleepy, drowsy, then the safety risk is associated, and you should educate them about that. Postural hypotension, that's also safety risk, especially older patient, and they can fall. Then dryness, then we tell them to drink more fluid and consuming more fiber to address dryness as well as constipation. Dextromethorphan can also cause to some extent that drowsiness, but not similar to your opioids. Benzoate can also cause moderate level of sedation, dizziness. That is also important to know, okay? So opioids and your benzoate are more, I would say, focus on this slow, sleepy, drowsy, dry thing, okay? And that's what we should be including when we talk about nursing implication, that what are the solutions for the problems? Well, for slow, sleepy, drowsy, we implement safety precautions and educate them not to consume anything which will suppress the same system. And they should not be driving or operating anything else. And once again, going back to what I said previously, simple statement that do not engage in any activity which requires you to be alert, because their response won't be normal. Their reflexes won't be normal. Okay. And always, when you're educating your patient, if they're given a prescription, always give them clear instructions like what to do, when to do, who to reach out. Tell them not only about how to take the medication, but also like, hey, if you say they have cough, right? Tell them if it does not resolve within a week, schedule an appointment, go see a doctor, so that they know that, hey, this is what the expected timeline is, that I should feel better. If it's not, maybe there's something else going on. Maybe they have an infection that's causing it. Then they need to be reassessed. Okay. Now, when you instruct that based on the severity of the symptoms, they should have that clear understanding who to reach out. If something severe happening, they can't breathe, then don't call the doctor's office, call 911. Go to the emergency department. But if it's something not resolved, but it didn't get severe, well, then call the doctor. Okay, now next, your expectorant. Once again, expectorant are for wet, productive cough. They make the secretions, the mucus, less thick and causes irritation, the mucosal membrane, and helps in coughing so that they can expel the mucus. So these patients may see more cough, they're coughing more initially. So in order to get the maximum effect, tell them to drink lots of water. Will loosen up mucus, easy to expel. So know how they work. It's important, okay, that how they work. Decreasing the thickness, the viscosity of the secretions in the respiratory tract so that they're easy to remove. And they will also increase the secretions in the, initially. The secretion are going to increase in the beginning. They're trying to expel, making thin, causing more secretions which are less thicker. And guaifenesin is a good example. Okay, we know this, that how does it work? So that's an important thing as well. Okay, expectorant, increase the mucus production and making it thin. That's the same what we just talked about, making them less thick, expelling them out, and important once again, educating a patient to drink lots of water, unless they're on restricted fluid intake, like, you know, some heart failure patients. And this is the same thing. Now let's talk about some herbal products. So patient try all kind of things, vitamin C, echinacea, golden seal, and for cough, like, you know, honey, which can soothe the throat and acts as a natural cough suppressant. Then people also use in some cultures licorice root, that also has soothing properties. Then some use ginger. Sometimes make like ginger teas and they add licorice in that. And marshmallow root, peppermint is also commonly used. So as far as echinacea, there's something important I want you to know. You tell the patient that this is not going to target the problem. Okay, this is an herbal supplement. It's derived from a plant, echinacea, to support the immune system, your immunity, your own immunity. It makes it stronger, makes your own immunity stronger to fight with the condition. It's not targeting the problem, it's making you stronger to fight with the condition. Does that make sense? Makes it clear? Okay. That is an important part because people do not understand the difference, that how these things act and what to expect. So it's not gonna just go and like suppress their symptoms, but yes, slowly to some extent it will boost their immune system and the symptoms will eventually get better. Now, anaphylaxis is a very severe and it could be life-threatening. It's an allergic reaction which happens rapidly, suddenly. Okay, it's not a chronic condition. Suddenly, within minutes of exposure to an allergen. Now, it could be? It could be just simple food. Peanut allergy is very common. Shellfish allergy could be because of an insect bite. It could be because of a medicine the patient is allergic to. Could be latex allergy, could be anything. Now, different type of reactions can happen. It could be a skin reaction, patient having itching, flushing, hives, or maybe severe respiratory issues. They can't breathe. There's swelling of the throat, difficulty breathing, the wheezing. Well, that's a red flag, very high risk. Cardiovascular symptoms, GI issues, nausea, vomiting, diarrhea as well. Some may even become unconscious. What can you do? Well, you need an immediate action. And the solution is epinephrine, EpiPen. People sometimes call this adrenaline as well, epinephrine. Usually, brand name, it comes as EpiPen, comes in different strength. So it comes as an auto injector. usually people who are at risk or who has some sort of severe allergies, they are recommended to keep at least 2 EpiPens at home or with them. So based on the severity, the symptom, you take action, and usually this is how it's given. Okay, this is how it's given. You don't need to remove the clothing. You can give it through the clothes, and always given on the side of the thigh. Okay, so you just kind of press it against the patient, and then against the thigh, and then press the button, and you will hear the click when it retracts, and then you can just pull it away. So this is the one which kind of reverses the effect, the anaphylaxis reaction, and then whatever the signs and symptoms associated with that response, they should reverse as well. But you have to monitor the patient because they may need additional dose, additional response. They may need supplemental oxygen based on the severity of the symptom. They may even need, in severe cases, an IV antihistamine or your steroids if they have some sort of respiratory inflammation to suppress that, to reverse that. You may need multiple drugs. They may even need a beta agonist, such as albuterol, so that they can breathe, open up the airway. Okay. Any question? Any question before we take a break?
No, Professor.
No question? All right, then let's take a 15-minute break and we will, what we'll do, we'll pick up the 3rd chapter and wrap it up. All right. Enjoy your break. I'll see you shortly, guys.
Thank you.
Thank
Thank you. See you in a few minutes. Excuse me. Right, welcome back, guys. Let's turn the cameras on. Excuse me. Ishan, are you still here?
Yeah.
What time did you came in? Because you were not able to scan the QR code, right?
Came in the power restored at 10:25, like 10:20, 10:20.
10:20? Okay.
Yes, sir. Can you guys see my screen again? Yes.
Yes, we can see it.
Excuse me. And you see the full screen, right?
Yes.
Okay, thank you. All right, let's move on. So last chapter of the day, it's a very important chapter, respiratory drugs. Okay, we'll talk about the conditions, respiratory conditions, and then we'll talk about the drugs and interactions, indications, contraindication, adverse effect, all that. So this chapter is associated with the drugs targeting the respiratory system. So respiratory system, the main function is to provide the oxygen and remove the carbon dioxide from the system. So you have parts divided, upper respiratory tract and lower respiratory tract. Alveoli is where the gas exchange occurs in the lungs. So this is how we look at the upper portion here. This is your upper respiratory tract, and going down from trachea and then bronchi, and then there's branches. That is all your lower respiratory tract. So the upper part that has your nose, the nasal cavity, sinuses, pharynx, your throat, and the larynx, which is the voice box we call. Then it does air passage uh, into the lower respiratory tract and also filters out any pathogens, dust particles, foreign particles. Also provides humidification and warming the air before it enters or reaches the lungs. And then olfactory is what supports the your smelling, the sense of smell through the nasal cavity. And your lower respiratory tract, it includes, as I said, like your trachea, your bronchi, and then further down your bronchioles and lungs within the alveoli. So the main function is the gas exchange, delivering the oxygen and taking carbon dioxide away. Then if we talk about the conditions, the diseases of your respiratory tract, so such as your lower respiratory tract, your asthma, COPD, and your bronchitis, emphysema, what happens is this is the normal airway, open, and the membrane is not swollen here, not inflamed, but with the conditions such as asthma, COPD. So this membrane of the airway gets inflamed. When the membrane inflames, it narrows down the airways. So when the airways are narrow, they're tight, then there's a trouble with gas exchange. There's not enough oxygen there. Your bronchial asthma, or you can just say asthma, simple. It's a chronic condition, chronic inflammatory condition of your airways, where a reversible airway obstruction happens because of inflammation, hyperresponsiveness. And the signs and symptoms commonly are, once again, associated with the system, respiratory system, such as wheezing, shortness of breath, it could be chest tightness, or the patient is coughing. Very commonly at night and early mornings, symptoms are more evident. It could be mild, very manageable, it could be severe. And the reason is that bronchoconstriction that's what happening, constriction of the bronchiole, and the drugs we give, they cause bronchodilation. Okay, we are giving them bronchodilators. Once again, it's just another way to look at it, that these are airways, see here, all open, but when they get inflamed here, then the airway becomes tight. A patient may experience different type of asthma, such as intermittent, when the symptoms occurs like, once here and there, like say less than twice a week, and the nighttime awakenings are kind of same way, less than twice a month, you say. Mild persistent is more than the symptoms occurs more than twice a week, but not every day, not every day. And they usually 3 to 4 times a month in the night, they wake up because of the symptoms. Moderate is when they pretty much have daily symptoms. And the severe persistent, that symptoms are continuous pretty much throughout the day. They're waking up at night. So that is much more severe as compared to the previous ones. As far as diagnosing asthma, you need to get patients' detailed history and also find out are there any known triggers so that you can suggest them, guide them how to prevent those triggers, because that's the best thing to do. Prevention is better than cure. Like, prevent if the triggers are known. Then spirometry is used to measure the forced expiratory volume in 1 second. It's called FEV1, forced expiratory volume in 1 second. And then the ratio calculated is FEV1 to forced vital capacity, which is FVC. And when you give them bronchodilator, then you should see that improvement in ratio. And then peak expiratory flow is when you measure the maximum speed of exhalation, expelling out, okay, exhale, for monitoring the asthma at home. And there might be different type of triggers. And looking into that, you need to figure out what would be the best way to address the patient needs here. If it's something because of where they work, they get exposed to certain type of chemicals, smoke, well, that's something they need to work and need to avoid those triggers, maybe wearing mask. Is it because of some sort of severe infections? Then we need to treat that underlying cause as well. Is it because of allergens in the environment at certain season, or is it food, pollen, dust, what it is? Then if it's because of the environmental issue, then tell them to avoid, and also using HEPA air filters at home that can help as well. And if it's because of a medication, very commonly can happen with NSAIDs or beta blockers, well, then they need to avoid those drugs. If it's because of a food, they need to avoid that food. People going through extreme stress, or you can also say emotional stress, that can also trigger. Okay. Here's a condition which is a medical emergency. It's a life-threatening condition. It's called status asthmaticus. Now, how it's different from asthma and why it's life-threatening. So usually when somebody experiences an asthma attack, you give them medication and that improves their symptoms. But in this condition, the patient does not respond to the standard treatment protocol. For example, you give them a bronchodilator, an inhaler, say short-acting beta agonist like Albuterol, but the patient still experiencing severe symptoms. You give them corticosteroid, same, didn't improve much. That condition is called status asthmaticus, and that's a medical emergency. Patient should be in the emergency room, right? Bronchitis. So divide into two: acute and chronic. Acute usually is viral, it's cold or flu. It can be because of bacterial, but that is less common. Viral is more common in acute condition. It is short term, usually week, 2 weeks, gets resolved. The problem is same. The airway becomes inflamed, the membrane, and the airway becomes tight. And the solution still stays the same, that we need to open up the airway, causing bronchodilation. The symptoms from mild to severe, a patient may have just kind of cough, with or without mucus. Maybe they're tired. The reason is, they're not having enough oxygen, which causes fatigue, shortness of breath. They're not able to do activities. They need to take breaks. Treatment is rest, more fluids. If it's cough, give them cough suppressants. And if they are having shortness of breath, we'll give them bronchodilators. And if the cause is an infection, along with bronchodilator, you may need to give them antibiotics if infection is bacterial. On the other hand, chronic bronchitis, it's a long-term irritation. It develops over a long period of time. It's not acute. Due to a long time exposure to certain irritants. Example, smoking, pollution, or occupational hazards that they work in facilities, some chemical factories, paint factories, those are at much higher risk of experiencing these conditions. And their symptoms are more persistent, lasting from, let's say like month, 2 months, 3 months. They're persistent, keep happening. The patient may have persistent cough with mucus production, shortness of breath, and they're getting more frequent respiratory infections as well. And the best way to approach is first to avoid what is causing it, making it worse, such as smoke. If it's smoking is associated with that, well, assess the patient's willingness for smoking cessation, encourage them, and if they're ready, educate and send them to the right resource, the right programs. Then bronchodilators, corticosteroids. Some patients may need even oxygen therapy. Look at chronic bronchitis and emphysema, as we just talked about chronic bronchitis. So but they're both, chronic conditions. Chronic, you can say the chronic COPD, the chronic obstructive pulmonary disease, but they affect the lungs in different ways. Chronic bronchitis, the main issue is inflammation of the airways, the bronchial tubes. On the other hand, emphysema, it is the destruction of the alveoli, which are the air sacs in the lungs. Okay, so bronchitis is the bronchial tubes, the airways. They're inflamed. But in emphysema, it's associated with the air sacs, the alveoli in the lungs. Everybody clear about the difference between both conditions? Now with chronic bronchitis, the patient may have persistent cough with mucus production for months. Okay, so they'll have cough, mucus, frequent respiratory infection, they're short of breath, and the cause behind is long-term irritation of the airway. As I mentioned previously, smoking, environmental factors such as pollution can play a significant role in that. Now, on the other hand, excuse me, with your emphysema, mainly you see that they have a reduced surface area for enough gas exchange, which results in difficulty in exhaling the air. There'll be shortness of breath, and they will get tired quickly, exertion, and their chest might be barrel shaped if the condition is real severe. And the cause could be the same, like smoking and environmental factor. This is how it looks like. Excuse me. Normal bronchioles, emphysema, right? This is how they get inflamed. There may be fluid filled in there. Smoking is one of the biggest cause, and exposure to pollutants in the air, chemical fumes, dust, those are biggest culprits behind that. Okay, now let's talk about the solution. The different approaches based on patient's condition, which we need to adopt, such as products which are under the classification of bronchodilators and others who are not bronchodilators. So bronchodilators, non-bronchodilators. Bronchodilator, how they act, they relax the smooth muscles around the airways, widen them to improve the airflow to the lungs. Okay. On the other hand, non-bronchodilator, they do not directly relax the airway, but help managing the respiratory condition by reducing the inflammation or controlling the symptoms that eventually causes that effect, but not directly. So now, going back to bronchodilators. Bronchodilators, remember BAM, okay? Just to for making it easy for to remember. BAM. BAM, B is beta adrenergic agonist, A are anticholinergic, M are methylxanthine derivatives. These are the common drugs used as bronchodilators. And your known bronchodilators, they are SLAM. S, steroids. L, Lutras, I call short term, leukotriene receptor antagonist. Montelukast singular is a drug from that class. And then mast cell stabilizer. Remember, they don't cause bronchodilation. They're addressing it differently. Because we know corticosteroids, steroids suppresses inflammation. That eventually help them breathe better. Leukotriene receptors, they block the effect of those leukotriene modifiers. They block the leukotrienes to reduce the inflammation and prevent the airway constriction. Mast cell stabilizers such as cromolyn, they prevent the release of histamine because histamine causes inflammation. Now let's talk about the drugs one by one. First, start with bronchodilators. So these are used to cause dilation in the airway, bronchodilation. Now, as far as bronchodilator, they're further divided into two groups, two classes, short-term and long-term. Now, how you can remember it, remember SABA and LABA. One side is SABA, one is LABA. SABA means short-acting beta agonist. LABA means long-acting beta agonist. Okay, everybody understood? Bronchodilators, your beta adrenergic agonist, they're divided into two, short and long acting, SABA and LABA. And I'll give you examples along with that. How many heard about albuterol? Guys heard about albuterol inhaler? Do you know, is that a SABA or is it a LABA?
ABA.
SABA, short acting. My next question is that used for acute condition or for chronic management?
Acute.
Acute, good job. So let's pick up the examples now, okay? And here's another way to put it in a table form. Short acting and long acting, SABA and LABA. Now pick up some examples from each class. For SABA, just remember albuterol. Albuterol is a SABA. What else is important to know? While it's used, we know that patients with asthma, but because it's a short-acting beta agonist, we know it will cause bronchodilation because of the type of bronchodilator it is, short-acting. So two factors to remember. It acts quickly, but it doesn't last long. Short-acting works quickly, doesn't last long. And that is the reason we use it in acute condition. That's why it is also called rescue inhaler. Rescue the patient in acute asthma attacks. And this drug is never used for chronic management. They're always as needed. PRN, they're as needed. They're never scheduled. Patient, if they're using it too much, too often, means they need to start or change, adjust their chronic management if they have to use the short acting too many times. Means their condition is worsening. It's not managed well. On the other hand, the long-acting beta agonists, LABA, they should never be used in acute condition. They're always scheduled for chronic management. So everybody clear about the differences between both type of beta agonists? Any question on them? No question? There's a 50% sale going on, guys, especially girls, 50%. Okay? Ask one question answered freely. Buy one, get one. No? Girls love shopping. Sale, come on. I want to use the opportunity. Lose your coupon, guys.
No questions, Professor.
All right, guys, if you say so. All right. On the other hand, the LABA, pick up example, maybe salmeterol or arformoterol. They come individually, but they come in combination as well, such as your, some of your inhalers, they has this LABA, and they may have like a steroid mixed with them as well, or anticholinergic along with that. Right. So as far as beta adrenergic agonists or bronchodilators, there are different types there. Selective, non-selective. And from that non-selective itself, it could be the non-selective adrenergics, means that they can stimulate alpha as well as beta, and within the beta they can stimulate both beta 1 and beta 2. Now we know that beta 1 are associated with heart, beta 2 associated with lungs. An example is epinephrine. So if a non-selective adrenergic is given while we're targeting the beta 2 respiratory, but it may produce some effect, unwanted effect on alpha and beta 1 as well. Okay. And then non-selective beta adrenergic means only on beta receptor, but it could be on both beta 1 and beta 2. And then finally, the beta 2, which are your selective, they are the one which are targeted specific for only the respiratory symptoms beta 2, such as your albuterol. So there are less chances of unwanted, undesired adverse effect produced by other drugs, such as your non-selective ones. Excuse me. Mechanism of action, how do they work? Well, they solve the problem. The problem was bronchoconstriction And the solution is bronchodilation, and that's a mechanism of action. They cause bronchodilation. What receptors? Beta adrenergic receptors. And we're talking about lungs here, beta 2 on the lungs, but non-selective, as I said earlier, may produce some effect on beta 1 as well, which are on the heart. And they can increase the heart rate and contractility of the heart. So we have to watch. This is how put it, like, receptors like beta 1 on your heart, beta 2 on your lungs. Beta 2 specifically will target here, but non-specific will spread out their wings and cause undesired effect. Now, indication. Who are our patients for these drugs? Well, we just talked about the conditions: asthma, COPD, anything associated with respiratory symptoms where they're having trouble breathing. They have bronchospasm, bronchoconstriction, and these drugs can cause bronchodilation. Now, short-acting used for acute attacks, long-acting are used to manage. Before giving this drug, the patient had bronchoconstriction. Maybe they have shortness of breath, having hard time breathing, and you give them the drug. How would you assess the efficacy of the medication? How can you tell the patient's symptoms improved or not? Any input, guys? Let's step back. What are the symptoms we're talking about? What patient experience with these conditions?
With asthma, bronchitis, or any pulmonary disease.
No. What do they feel? The symptoms?
Shortness of breath, trouble breathing.
Okay, so if you have to determine that the drug you gave, it helped the patient or not, what would you expect? How would you assess?
They are able to inhale or exhale comfortably.
Okay. Now, let me point out here something important. What part of the body we're talking about? Where's the problem?
Their lungs.
Lungs, right? Then
So when you assess them, they sound clear.
best way to assess is where the problem is, right? Listen to the
Lungs.
breath sound. If they are clear, there's no adventitious sound, there's no wheezing and all that. And well, that's right there tells you that if patient is feeling better or not. Agreed? Yes?
Yes.
Okay. Contraindication. Who should not be given this drug? Well, you could be at high risk. Remember that these drugs, especially non-selective, can go on a walk just to say hello to heart, but there, when their visit, can stress out the heart, can increase the tension there, right? Hypertension. So anybody who has hypertension, we should not be giving it to them. Fair, right? Somebody who has cardiac dysrhythmia, their they have that underlying condition, they should not be given this? Because the reason, these non-specific drugs, we told them to help the patient the problem related to lungs, but they had spare time, so they decided to visit heart. And even though they cause bronchodilation in the lungs, but when they go to heart, they increase the tension by constriction, vasoconstriction, and increase the blood pressure. We need to consider that. Okay. Once again, if they are not specific, they're non-selective, along with the lungs, they will travel to cardiac muscles and they will cause constriction and will increase the blood pressure and heart rate. So that is an important thing to remember about them, guys, okay? So that is the most common side effect, changes in heart rate and blood pressure. Interactions. Well, here comes the gentleman again. Monoamine oxidase inhibitors, MOAI, can make hypertension severe. Excuse me. Even hypertensive crisis. Now, another important thing. You have to monitor blood glucose more frequently in your diabetic patients. The reason, they will increase the blood glucose. Okay. So just remember these things. They will increase the tension where? Heart. So it will increase the heart rate and blood pressure, and in diabetic patient, it will increase the blood glucose. Here comes one of the most common from this class, your Sabas albuterol, short-acting beta agonist. Now, once again, these are used for acute symptoms, not for maintenance. Patient, if they're using it frequently, if they're saying, oh, you know what, I'm just, have to use it every single day. I don't know what to do. Well, then means their condition is worsening. They need to make changes in the chronic management side of the treatment if they have to use the acute treatment too often. Now, these drugs comes in various forms, such as meter dose inhalers called MDIs, where the drug is in aerosol form. Right? You see albuterol inhaler, you press and you see the drug coming out, right? Minute microparticles, because they are packed under high pressure. And as you press, gives them an opportunity to come out, and they're happy. Then there are drugs which are in powder form. They're DPIs. They're called dry powder inhalers. If it's an inhaler, no matter what type of it is, it's a basic instruction, but one of the most crucial one, as yesterday we're talking about insulin pump. So this is also a device. It's extremely important that you demonstrate, first show it to them how to correctly use it, and then ask them to give you a return demonstration. Because this is a common drug where people commonly use it incorrectly. They waste it. And then people complain, oh, you know what? I don't know what this doctor is giving, and I'm spending so much on this inhaler. It doesn't help me at all. And when you tell them, like, okay, can you show me how to use it? And you realize that they're not even using it correctly. For example, some of the inhalers, you may need to shake it first and then prime it first, getting it ready to release the dose. You may have to prime means that you shake it and you press it a few times until you see a smooth pattern of the aerosol that are coming out. And some don't need to. You need to read the manufacturer label. What are the requirements for that? Second, you need to see excuse me guys, the whether it's a meter dose inhaler or it's a dry powder inhaler. The difference between them is how you inhale. How you inhale. For example, if it's a meter dose inhaler, like this one, Albuterol, because it's pressed, the drug is pressed in a tight pressure, and as you press, it will come out easily. So when you inhale, you don't need to put up extra effort. So first thing is exhale. That's the first step, whether it's a aerosol form, the meter dose, or it's a dry powder DPI. Exhale so that you can make room to inhale. Second, make a tight seal with your lips, okay? And as they press, inhale. Now, here's the difference. If it's a meter dose inhaler, you inhale slow and deep. Slow and deep. But if it's a dry powder inhaler, it's a powder. You need more suction, stronger suction to pull it out from the little box, the inhaler. So the instruction should be to inhale forcefully. That is the difference. Because if they are trying to inhale, but it's not strong and it's a powder form, they're not getting any drug. Next step is equally important. Hold your breath for at least 10 seconds or whatever the maximum they can. The reason, the drug has to come in contact with the lungs to get absorbed and produce its therapeutic effect. If they exhale right away, the drug now expelled out. How it's going to produce action? Nothing is going to happen. So these are crucial steps which you need to make sure the patient understand. Okay, everybody clear? Any question on that? All right. So if no question, let me add a few things here. Suppose patient is using one inhaler and they're going to use more than one puff. Then tell them to space it out 1 to 2 minutes between each puff. Excuse me. What if they're going to use more than one inhaler, different inhaler? Then make sure it is important that you space out 5 minutes. Okay, space out. Now the next question is, if there are two inhalers, which one should you use first or second, or does it even make a difference? The answer is yes, it has to be used in certain order. The first one should be a bronchodilator. A bronchodilator, so that you can open up the airway and then use the second one, the drug, that can be absorbed well. If the airway is constricted, not enough or open airflow, the drug is not going to reach. And less absorption, it's not going to be effective. So always bronchodilator first. This is an example. You see this round disc. This is a dry powder inhaler. This is the mouthpiece. When you pull it on side, the dose gets loaded. And you hold it like that and inhale strongly and deep. Okay. And your Salmeterol, this is your long-acting one. So never for acute, always for maintenance, chronic management. And they are always scheduled. They're never as needed. Nursing implication regarding them, it starts from how to correctly use, and the best method to assess your patient is asking them to give you a return demonstration. Otherwise, as you're holding the breath for 10 seconds. Also, if the patients are taking such as like steroids, right? Ask them to perform oral care, technically rinsing their mouth after each use. They ask why can cause fungal infections. And associated sign and symptom to monitor is white patches inside the mouth. Now, another point here is an example I would pick up, say, Albuterol. A patient uses Albuterol, and they're saying, oh, you know what? I just, this is a new inhaler, Albuterol given to me, and I used it, and I noted like I used it twice, and I felt like a little shakiness in my hands, slight tremors. Asked them how severe was it, how long it lasted, and how many times. Because this is common in the beginning, slight shakiness or like mild tremors in the hand is normal in the beginning, but it should not be the case. It should not keep happening. I would say after a few uses, it should not be there. But if they call you, say like, hey, I used it, had mild shakiness, tremors, well, monitor. But other than that, that's expected. Okay. Now here's another class, anticholinergics. They're called LAMA, not LAMA. LAMA means long-acting muscarinic antagonist. Simply anticholinergics. And now, if you think anticholinergic, once again, try to think about Benadryl, diphenhydramine. What does it make your patient feel like? You know, slow, sleepy, drowsy, dry. So if they're on this medication, they will experience similar symptoms because it belongs to same class. It's not the same drug, but it is in the same class because it acts on the same type of receptors and gonna produce the same kind of adverse effects. Now, how these anticholinergic work? Remember, now break it down. Anticholinergic separate anti and cholinergic. So they are against the cholinergic, means cholinergic receptors. So they're gonna block the cholinergic receptors. Okay. They prevent bronchoconstriction by blocking the acetylcholine at the cholinergic receptors. And these are used commonly, in COPD patients, sometimes in asthma, but more common in COPD. Now, what are the examples? There are two easy to remember and most commonly used. They're ipratropium, which is atrovent, ipratropium, and tiotropium. Aprotropium and tiotropium. Adverse effect, as I said, remember about diphenhydramine, same effect. Slow, sleepy, drowsy, dry. Here's the ipratropium and your tiotropium comes alone or in combination. And this is your inhaler, and this is your DPI, dry powder inhaler. So they block your acetylcholine receptor in the airways, causing bronchodilation, widening of the airways. Used commonly in COPD, less commonly in asthma. Example, ipratropium, tiotropium, these are the most common ones. And there's new ones here, your aclidinium, omaclidinium, these are the newer ones. Contraindication stays the same. Once again, go back, step back, think about who we should not give the Benadryl. Remember those? Glaucoma, BPH, pregnancy, same thing. All right, next class. Your xanthin derivatives, theophylline and aminophylline, and theophylline is the only one used as bronchodilator. Okay, aminophylline more like in as in acute conditions, exacerbations use. They act by inhibiting phosphodiesterase. What it does is that it causes an increase in the CAMP, cyclic AMP, which produces the bronchodilation. To some extent, very low, mild, but they do have an anti-inflammatory effect as well. Now about them, what is important is there is, I think, an interaction which is more important for us to know. Okay, here it is. This is how your theophylline aminophylline looks like. Your aminophylline, which, as I said, like in more acute exacerbations, patient in emergency department, usually given as an IV. And very commonly, patients with that life-threatening condition, that status asthmaticus, when they're not responding to the usual treatment. Okay. Now, important to know, another thing is that theophylline is also one of those drugs which has a narrow therapeutic index. Means the minimum effective dose required to produce therapeutic effect and the maximum dose which can be safely taken is very little. So a slight increase in the dose can cause toxicity in the patient. So you have to be careful in dosing and also monitoring the serum therapeutic level because it could be toxic real quick. And I think I suggested in the beginning as well, when you come across certain drugs where you need monitoring or do certain things, put them in a list, like, drugs with a narrow therapeutic index, and theophylline should be added into that. You will have more drugs like digoxin, you will have warfarin, you have phenytoin. As you come across the drugs, put them in relevant sections so that you can remember them easily by organizing in a single list and make a mnemonic of that list. So then you remember only 4 or 5 mnemonics that, oh, these are the drugs with the narrow therapeutic index, and know the serum drug levels. For, for example, here, theophylline should be between 10 to 20. For warfarin, the normal INR should be between 2 to 3. Same carbamazepine, phenytoin, we need to know those things. Similar way, if you come across a drug which can cause some sort of severe concern like liver toxicity, write down drugs, or you can say hepatotoxic drugs. Keep writing whenever you see that drug, when I point out, highlight it, which is important, add to that. And same way, if drug is nephrotoxic, which can cause toxic effect to patient's kidneys, make a list. So similar way, you create 4 or 5 lists and then create a mnemonic for all of them. That will make it easier for you to answer the questions whenever you're going to see them. Otherwise, they will get mixed. Okay. Not worried much about that, guys. Here is important again. So interactions here important with your xanthine derivatives. Either they ask you about as a class, or they ask you about theophylline or aminophylline. It's important you ask the patient that you smoke. Okay. You smoke. Cigarette smoking can put your patient at risk of toxicity. And those drugs we already just talked about, that they already have a narrow therapeutic index. And if they smoke, patient may experience toxicity. Also, tell your patient not to drink caffeinated products. Okay, here comes another important class. Your LUTRAs, LTRAs, or leukotriene receptor antagonist. And then there are corticosteroids, mast cell stabilizers. So let's talk about that one. Don't worry about this thing. Okay, here's a leukotriene receptor antagonist. As the name says, they block or antagonize the effect of leukotriene. Used in asthma, allergic rhinitis. One of the most common drug is your montelukast, which is a generic for singlet. The other drugs, zafirlukast, Zolutin, but most common is montelukast singlet. What it's used for? Well, allergic rhinitis, more commonly, long-term management of asthma. There's one thing I want you to remember about this drug, which is very important. When to take this drug. The frequency is once a day, 10 milligrams. It's important to educate the patient to take at bedtime. It causes sedation, drowsiness, safety risk. So we need to make sure we convey that to patient. It should be taken once a day at bedtime. That is important about this. Okay, talk about it that they block the leukotrienes, which cause inflammation, bronchoconstriction, also increase the mucus production. And when you block, they're not able to cause all those things. All right, indications, same thing what we talked about. For your chronic management of asthma, and if patient experiences that like seasonal allergies, to prevent that from happening, it can be used as well. Okay, but not for acute attacks. It doesn't work right away. And who should not be taking it? I'm not worried much about it. These are other drugs. I'm not worried about them. All right. So once again, important things here. It's for chronic management, not for acute. And once again, the most important thing to educate your patient about the frequency and the time. Frequency is once a day and at bedtime. Okay. Any questions so far, guys? You want to clarify? Everything is clear? Yes? All right. Super nurses say it's clear. It's clear. All right, guys. Let's move on. Here comes the corticosteroids. And we know in general, corticosteroids, they have the most common use as anti-inflammatory. And here we are specifically talking about inflammatory conditions of the respiratory tract, right? So they are used for managing chronic asthma, not for acute. Acute are the SABA, again, always short-acting beta agonist, albuterol. They may take as pills, or it could be inhaled. Well, everybody have their properties and never changes. Like good is good, bad is bad, right? So these guys, same thing. When a drug belongs to a class, no matter what you're using for, it's going to have same type of good and bad effects. Now, can you please refresh my memory? What are the adverse effects associated with steroids?
Immunosuppressants.
Uh-huh. Good job. Anything else? So suppress the immune system. Patient might be at high risk of infections. Then how about blood pressure? What happens to blood pressure?
It worsens and increases it.
Increases. How about blood glucose?
It increases the blood glucose.
Yeah. So even though we are using it for respiratory condition, it's still going to do other things. Another one, very important point I want to add here is no matter, and the same concept applies that they're going to do what they do. These drugs, when used regularly, increase patients' risk of GI bleeds as well, especially when they are taken with NSAIDs. Okay, taken with NSAIDs or aspirin, it increases your patient's risk of GI bleeds. Now, what if the patient is experiencing a pain? What a super nurse will give?
Tylenol.
Tylenol. There you go. Acetaminophen. That's what you can give. It's important to know because patient doesn't know these things. That's only super nurses, right? So they rely on you to stay safe. Okay. Mechanism of action, as I said, nothing complex. You need to remember that they reduce the inflammation. They inhibit the molecules, inflammatory molecules, which causes all this issue inflammation, such as your cytokines, chemokines, arachidonic acid, those things. So they block that so that there's no inflammation, suppress the inflammation. You don't need to memorize this. It's a little more complex. You don't need that. Now, let's talk about these inhaled corticosteroids. You see these inhalers there. These are your meter dose inhaler. This is your DPI, dry powder inhaler. It's a mouthpiece. You load the dose by pulling it on the side and just to mouth. And you need to know, again, that you need to know how they work, and we know that anti-inflammatory, but associated things you need to also educate the patient about, that this is what you may experience. And hey, these are the signs and symptoms you should be monitoring. And if you experience that, you should reach out, because there's a high chance that those are going to come along in that package. And do you remember what I told you about steroids? They should never be abruptly stopped. Right? Never be abruptly stopped. So even though they're used for respiratory condition, same concept applies. They should never be abruptly stopped. What is the condition called if you abruptly stop and you do not taper the steroids? Excuse me.
A rebound effect?
Oh, that one was associated with your decongestant. I'm talking about a condition.
Withdrawal syndrome.
Those are generalized terms. So it is called adrenocortical insufficiency. It's related to the gland who produces it, adrenal gland. So gland was not prepared and you put it in shock. When you pulled it back all of a sudden, was not prepared to fulfill that gap, and the condition called adrenocortical insufficiency. That's why you always taper it down. Who should not be on it? Well, it stays the same. Anybody allergic, or they have a severe infection, something going on which can increase the risk, they should not be taking that. This slide is important. I mentioned it previously as well, but because it's important, so here it's again. Adverse effect can cause kind of a dryness in the mouth and throat, so they may cough, and experiencing that dryness in the mouth, and patient at high risk of developing oral fungal infections. And what did I mention earlier? What to watch for?
White patches.
White patches in the mouth. So one is signs and symptoms, which you should tell the patient to monitor, look for, that, hey, these are indicators of a problem. If you see this, this is the problem. You need to reach out. In order to prevent that from happening, here's the solution. Every time you use it, rinse your mouth. That will reduce the chances of developing this condition, right? Now, it is normal, as I mentioned previously, that slight mild tremors, shakiness in hands. Educate them. This is expected in the beginning for until few doses they take. Usually 2-3 days it should go away, but it is expected in the beginning. And once again, whether it is a tablet form or it's an inhaler, if it's a steroid and patient is on NSAID, they take NSAID, can cause GF bleed, and if they need anything for pain, super nurse says, super drug, acetaminophen, Tylenol to give. Okay. Now, as we talked about it multiple times, increased blood pressure, increased blood glucose. So if your patient is diabetic, it's real important that we monitor their blood glucose, check it more frequently. All right, here's another thing which is important, especially in child. Now, kids don't know that how important it is or how to exactly do that, that you can synchronize your breathing with the drug release. So the kids may not be able to inhale properly and hold the breath to produce therapeutic effect. That's where comes this device called spacer device. You guys heard about that spacer device? Yeah? Okay. So this is a very useful piece. It's nothing. It's just like a small piece of pipe. And on one side, you stick in the inhaler, gets locked. Other side, there's a valve, one-way valve. You can inhale, but as soon as you stop the inhalation, the valve stops the drug from going out, getting lost. Because kids, when they can't synchronize the breathing, they will do a little bit, but the rest of the drug goes in the air. Or they cannot inhale strongly and they did and then gone. So what you can do is use this spacer device and let the kid breathe. Even though little by little, the rest of the drug is still in that tube, the spacer device, it's not lost. They can just inhale it multiple times. Now, if they're using inhaler, I told you to do frequent oral care. Along with that, also tell them to wash the mouthpiece, just this clean mouthpiece here. Don't just kind of try to drown the whole inhaler in water. Just the mouthpiece. Maybe they can wear a cloth and they clean it. And same thing applies if they're using a spacer device, they should clean that as well. Okay. And same concept applies, multiple medication, bronchodilator goes first and space it out by 5 minutes if they're more than one. And it's a steroid. You need to stop, never abruptly stop, taper it down. And how do you assess if the patient feeling better? Listen to the breath sounds. And whether it's an inhaler alone or you're giving them a spacer device, show them how to use it, ask for a return demonstration. All these points clear to everyone? You're on the same page? Any questions?
No questions so far, Professor.
All right. I tried to point out important things multiple times. Make sure you know that. Okay, then for some conditions, more severe, they're monoclonal antibodies. Monoclonal antibodies, they are biological drugs. They are designed to target like specific components of the immune response in case of asthma. So they are typically used for patients with moderate to severe asthma, particularly those with allergic types that do not respond well to the standard treatment plan. Or inhaled corticosteroids, it doesn't respond to that. And that's when you step up with these therapies. They usually end with Zumab at the end, like mepolizumab, omalizumab, raflizumab. These are your monoclonal antibodies. They target immunoglobulin E, IgE, called for allergic asthma, prevents the IgE from binding to the mast cells and then reducing the allergic reaction. Your mepolizumab is your interleukin 5, which is for more eosinophilic asthma. Then there's a Dupixent, which is a dupilumab, which is interleukin 4, and interleukin 13. That's what the pathway it blocks. Nursing implications. Well, first thing is, as I said, avoid which causes problem.